Well, good afternoon and welcome everyone. My name is Kathleen Borain. I serve as the Maryland Insurance Commissioner. And today I am pleased to have you meet with us as we walk through sort of our annual life and health industry meeting. It gives us an opportunity to talk about what happened in the last legislative session and how we will be addressing implementation tasks that have been given. It gives us an opportunity to talk about reports that we've been asked to do, whether formally or informally, and just to catch up on regulation of the life and health industry in general, and take some of your questions as well. So as we dive in, and before we dive into this year's agenda, let me just start by saying that this is a virtual meeting. It is being held via the Zoom webinar platform, and it is being recorded. The video and sound recording will be made available on the MIA's website within the next few days. I think that as we go through, and we'll pretty much save questions for the end unless there's something specific that the presenter feels like we want to hear comment on during the presentation. But other than that, we'll save questions and comments for the end. If you do have a question or you do want to make a comment, then please just let us know via the chat function or the hand raise option. As time and technology allow, our plan will be to call on folks in turn, move them over into the panelists section if we can, and at that point ask you to unmute your line so that you can make your comment or ask your question. But to make sure that we have really good sound quality throughout, please just stay on mute unless you are speaking. So again, as we get started today, let me just take a minute to acknowledge the members of the Maryland Insurance Administration who are here with us today. Let me start with David Cooney, who's the Associate Commissioner for Life and Health. Mary Quay, who's the Associate Commissioner for Market Regulation and Professional Licensing. Joy Hatchett, the Associate Commissioner for Consumer Education and Advocacy. Jamie Sexton, currently the Director of Legislative and Regulatory Policy, but soon, and certainly by the end of this month, to be Associate Commissioner Sexton. We have Riley Williams here who is our Assistant Director for Legislative and Regulatory Policy. And there are two faces that are not always in these meetings, but we have some exciting news that we're going to be sharing a little bit later on. And let me introduce to those of you who do not know them yet, Ruth Gedeshaw, who's the Director of Consumer Health Coverage Assistance, and Patty Dorn, who is our Health Insurance Administrator at the MIA. And of course, last but not least, Craig I and his capable team are on the call. And if you have any technical issues or questions, you can reach out to Craig and he will try to assist you with whatever issues they may be having. So with that, I am now going to turn this over to Associate Commissioner Cooney to start our agenda.
All right. Thank you, Commissioner. So I'm going to go over life and health operations, and I'm going to start off with a selective recap of the 2024 legislative session. So the MIA's annual legislative summary bulletin should be issued very shortly. And that bulletin will summarize all of the 2024 bills at any type of insurance impact in detail, but I'm just only going to mention a few today. And first up is House Bill 1074, Senate Bill 684, which deals with the reporting requirements for mental health parity, non-quantitative treatment limitations under Section 15144 of the insurance article. Now, I'm sure that all the carriers subject to the law are already very, very familiar with the history and backstory to this bill, but the bill is a result of recommendations made by the MIA in our interim report on non-quantitative treatment limitations and data that was submitted to the General Assembly in December of last year. The report outlined in detail the challenges and struggles the MIA encountered reviewing the NQTL reports and reaching parity determinations under the process that's outlined in current law. The MIA's interim report included 8 recommendations for how to revise the existing law to make the reporting requirements more effective and efficient. The MIA worked tirelessly with legislators, consumer advocates, and the carriers to convince stakeholders of the need to implement the recommendations as quickly and comprehensively as possible. And we were very pleased with the final result, and we're optimistic that the reporting process will be significantly improved this time around. The biggest changes to the law are the reduction in the number of NQTLs that will be required to be reported on each period, and also enhanced enforcement tools for the MIA in the event a carrier fails to submit a sufficient analysis that would allow the MIA to reach a parity determination. Reports must be submitted by carriers on July 1st every other year, and the commissioner will designate at least 5 NQTLs for each reporting period. If the MIA finds that the initial reports submitted by a carrier are incomplete or insufficient, in addition to our current authority to impose fines, we now also have authority to charge the carrier for additional expenses incurred to review subsequent reports, or we can order a carrier to either modify or cease the use of an NQTL, submit periodic data related to the NQTL, or establish specific quantitative thresholds for its evidentiary standards when appropriate, and conduct a new comparative analysis. Furthermore, carriers now have the burden of persuasion to demonstrate that the design and application of an NQTL complies with the Parity Act, and the carrier's failure to provide a sufficient comparative analysis will be considered a violation of the Parity Act. Additional noteworthy changes in the law include replacing plan-level reporting with product-level reporting, clarifying that carriers must provide an analysis for legacy processes originally implemented prior to the enactment of the Parity Act, if those processes continue to be a factor in determining whether or not to apply an NQTL. The law also expressly authorizes the commissioner to develop required data templates to support the in-operation analysis, and also to require carriers to submit data more frequently than every 2 years. And finally, the law codifies specific time periods within which a carrier must provide a comparative analysis for any NQTL, not just the ones that are subject to reporting for that year, upon request by the MIA or a consumer. So implementation for this bill is already well underway. The MIA issued Bulletin 24-10 on April 15th to provide the filing instructions for the reports that are due on July 1st of this year, to announce the first 5 NQTLs, and also to solicit comments on the new data supplement forms that we developed. For 2024, the 5 NQTLs are the prior authorization review process, prescription drug formulary design, provider including facility reimbursement, strategies for addressing provider shortages, and provider network directories. On Friday, May 24th, we then posted updated template forms and instructions for completing the forms on the MIA website in response to the public comments we received based on the bulletin that was issued. For the most part, the revisions were limited to providing clarification on various issues raised in the comments. Due to the short time period between finalization of the template forms and the July 1st filing deadline, we elected to minimize substantive changes to the data supplements, and we generally refrain from adding new data elements at this time. However, we do fully intend to revise the data supplements again in the next year to include additional data elements, and we will post the revised templates for an additional 30-day public comment period prior to implementation. Next up is House Bill 571, Senate Bill 485, which made revisions to Maryland's Family and Medical Leave Insurance Program, which was first enacted in 2022. The 2024 bill further delays implementation of the program, and contributions to the program are now set to begin on July 1st, 2025, while covered employees will not be eligible to begin receiving benefits until July 1st, 2026. While the state program is a public program that will be implemented and administered by the Maryland Department of Labor, the law does include a provision whereby an employer can request an exemption from the state program if the employer offers a private employer plan that meets or exceeds the benefits and protections of the state program. The private employer plan may consist of employer self-funded benefits or insurance purchased through an insurer licensed by the MIA. The bill in 2024 repealed text in the existing statute that would have also permitted the private employer plan to consist of a combination of insured and employer self-funded benefits. So this change simplifies the evaluation of the private employer plan by requiring the plan to provide comprehensive coverage for all the family benefits in order to qualify for the exemption. If the private plan is an insured plan, then it comes under MIA jurisdiction, and the forms and rates will be required to be filed with the MIA for review and approval. Because we have not previously received or approved insurance products that would satisfy the requirements for the family program, we've been working very closely with MD Labor since last spring to ensure that the insured private products will be available and ready to go when the time comes. But with the delayed implementation, however, we now have additional time to prepare for these filings. So based on discussions with MD Labor and the life and health carriers who have indicated that they plan to offer these products in Maryland, we're currently working from a timeline that anticipates MD Labor will finalize their regulations for the family program in late 2024. MIA and MD Labor will then determine the applicable requirements for the insured family products, and the MIA intends to issue a bulletin to carriers around April of 2025 with filing instructions and a policy template. We expect to impose a filing deadline for carriers of October 2025 in order to ensure that the filings will be all approved by February of 2026. We plan to approve all the initial filings in one batch to avoid giving any particular carrier a competitive advantage. This will then give carriers 5 months for product rollout and sale to have contracts in place by the time benefits are available under the family program on July 1st, 2026. I also wanted to mention that we've already received a handful of filings from disability carriers for products offering family and medical leave type benefits. So although we are reviewing these products as health insurance and will approve them if they comply with all MIA requirements, carriers should be aware that any products approved before the family-specific filing guidance is issued by the MIA will not satisfy the MD Labor requirements for an exemption for the private insured option under the state program. All right, now I'm going to move on to the utilization review bill. House Bill 932, Senate Bill 791 made sweeping changes to Maryland's prior authorization and utilization review laws, and it was a culmination of a multi-year effort to identify prior authorization reforms that healthcare providers, patient advocates, and insurance carriers could reasonably agree to accept. The law changes are far too numerous to summarize in detail during this meeting, but they go into effect on January 1st, 2025, and I'll briefly highlight some of the more impactful changes. The bill first imposes new requirements on carriers and healthcare providers under Section 19108.5 of the Health General article related to the establishment of an online process for approving electronic prior authorization requests for pharmaceuticals. The bill then includes various cleanup, clarification, and alignment revisions to numerous sections of the insurance article related to prior authorizations, time periods for determinations and notices, content of adverse and grievance decision notices, and other existing utilization review requirements. The bill significantly limits the circumstances when a carrier may issue an adverse decision on a reauthorization request for a prescription drug being used by a member that is an immune globulin human or is used to treat a mental disorder. The bill also modifies the statutory parameters for a private review agent's utilization review criteria and standards for determining medical necessity, including adding a stipulation that the criteria must be developed by a nonprofit healthcare provider, professional, medical, or clinical specialty society, with certain exceptions. The bill provides that if a private review agent fails to make a determination to approve or deny a request within the time limit specified in the statute, the request will be deemed approved. The bill also changes the existing voluntary peer-to-peer review process under Maryland law to make it mandatory and to include clear guidelines for how the process must be conducted. The bill revises the required qualifications for individuals authorized to render adverse and grievance decisions to mandate that those individuals must have actual clinical experience related to the requested healthcare service or treatment. So these and other revisions under the law will require significant changes to the prior authorization and utilization review procedures used by carriers and private review agents in Maryland. It will also require filings with the MIA to amend insurance contracts and update private review agent applications. There's also uncodified language in the bill that requires the Maryland Healthcare Commission, in consultation with the MIA, to conduct a literature review of the gold carding prior authorization review standards that have been implemented in some other states, and then report to the General Assembly by December 1st, 2024 on what we found. The uncodified language also directs MHCC and the MIA to monitor the progress toward implementing the online process for approving electronic prior authorization requests for pharmaceuticals under the newly enacted 19-108.5 of the Health General article. Lastly, in light of all the changes under House Bill 932, Senate Bill 791, the MIA issued Bulletin 2413 on May 24th to remind carriers of the Maryland law requirements with respect to utilization review of prescription drugs, including step therapy. The bulletin focuses on the circumstances when a carrier is permitted to consider prescription drug costs as a factor in a utilization review determination. As explained in the bulletin, if a member has been using a previously authorized drug, which, in the opinion of the prescriber, remains effective in treating the member, the circumstances when a carrier or private review agent may deny coverage due to the existence of lower cost alternatives is very limited. I highlight this point because this seemed to be an issue of contention when the bills were being considered by the legislature. The next three laws I'm going to hit, they all relate to new or revised health insurance mandates, and they will all require revisions to form filings for contracts that will be issued or renewed on or after January 1st, 2025. The first bill is House Bill 865, Senate Bill 614, which was called the So Everybody Can Move Act. The final bill was substantially scaled back from the version that was originally introduced, which would have broadly mandated coverage for orthoses in addition to prostheses, and which imposed several additional requirements related to network adequacy and benefit denial notices specific to these benefits, which were very unusual provisions for a mandated benefit. The final bill eliminated all the provisions related to orthoses and just made revisions to the existing mandate for prosthetic devices under Section 15-844 of the insurance article. Some of the revisions include expanding the definition of prosthesis to specifically include custom designed, fabricated, fitted, or modified devices to treat partial or total limb loss, requiring coverage of replacements of prostheses or prosthesis components when the ordering healthcare provider determines that the replacement is necessary for specified reasons, and also requiring coverage when the treating healthcare provider determines the prosthesis is necessary to complete activities of daily living and essential job-related activities, or to perform physical activities to maximize whole body health. The bill also requires carriers to report on compliance with the law for years 2025 through 2028, and that report is due by June 30th, 2030, using a form developed jointly by the MIA and the Department of Health. The MIA and MDH must then submit a joint report to the General Assembly by December 31st, 2030, summarizing those findings. The bill also directs the Department of Health and the Maryland Healthcare Commission, in consultation with the MIA, to study the cost impact of mandating coverage for orthoses for Medicaid and the commercial market, with the report to the General Assembly due on December 1st, 2024. The next mandated benefit bill, House Bill 1259, makes minor changes to two existing health insurance laws that were just enacted last year. Specifically, the law revises the cost-sharing prohibition for diagnostic breast examinations and supplemental breast examinations under 15.814.1 of the insurance article to clarify that image-guided breast biopsy is included under the definition of a supplemental breast examination, and therefore it's also covered by the cost-sharing prohibition. The scope of the existing law did not change, and because this law is a cost-sharing prohibition rather than a benefit mandate, it applies to all individual small group and large group plans, including plans sold through the exchange. The bill also revises the mandate for diagnostic imaging for lung cancer under 15.860 of the insurance article to mandate coverage for the lung cancer screening and to prohibit prior authorization for the screenings and follow-up diagnostic imaging. The benefit mandate portion under Section 15.860 applies to all large group plans and all grandfathered individual plans. However, because of the benchmark plan requirements under 31-116 of the insurance article, the benefit mandate does not apply to non-grandfathered individual and small group plans. Section 15.860, however, also includes cost-sharing requirements that generally have the effect of prohibiting cost-sharing for lung cancer screening and follow-up diagnostic imaging. The cost-sharing requirements have broader application than the benefit mandate, and they are applicable to any plan that provides coverage for lung cancer screening and imaging, including non-grandfathered individual and small group plans sold through the exchange. Finally, House Bill 1339, Senate Bill 778, creates a new mandate for hearing aids for adults, which mirrors the existing mandate for hearing aids for a minor child under 15.838 of the insurance article. The mandate itself applies only to large group plans and to grandfathered individual plans, and does not apply to non-grandfathered individual and small group plans due to the benchmark plan requirements. However, non-grandfathered individual and small group plans are already required to cover hearing aids for adults due to the ACA prohibition on discriminatory age limits. The new adult hearing aid mandate allows carriers to limit the benefit to $1,400 per hearing aid for each hearing impaired ear every 36 months. However, because hearing aids are an essential health benefit under the Maryland benchmark plan, the dollar limit under the new mandate will only be permissible for a small subset of plans that are subject to the law. The dollar limit will be permitted for any grandfathered individual health benefit plan because the ACA prohibition on annual dollar limits on essential health benefits is not applicable to grandfathered individual plans. On the other hand, grandfathered and non-grandfathered large group plans are subject to the ACA prohibition on annual and lifetime dollar limits for any service that is an essential health benefit. This means a large group plan issued in Maryland will only be permitted to include the $1,400 limit on adult hearing aids if the carrier has chosen to define essential health benefits for the large group market using one of the permissible alternative options under the federal regulations that are not based on the Maryland benchmark plan for the individual and small group markets. And that closes out the mandated benefits, but there was one other bill I want to discuss briefly today, and that is House Bill 827, Senate Bill 821, which requires the MIA to conduct a study on professional employer organizations in the state, also known as PEOs. The Maryland General Assembly has historically been very protective of the small employer health insurance market in Maryland. Consequently, while PEOs are authorized to operate and offer their services in Maryland, Maryland law requires that health insurance purchased by a small employer using the services of a PEO must comply with Maryland benefit and rating rules for small group insurance. Maryland is apparently the only state in the country that prohibits small employers from purchasing large group health insurance when they lease employees from a PEO. Concerns are consistently raised by certain stakeholders in Maryland that allowing small employers to purchase large group insurance through a PEO will draw healthier than average employers out of the small group market and drive up rates for the remaining pool members. In recent years, when various bills were introduced to change how health insurance purchased through a PEO is treated under Maryland law, the General Assembly responded by revising Maryland law multiple times to further clarify that a small employer who leases employees from a PEO will still be considered a small employer for health insurance purposes. However, the issue has been raised recently that it is unclear whether there's actually any data to support or refute the concerns that PEOs may have a negative impact on the rate pool for the small employer market. Consequently, the bill passed by the legislature this year requires the MIA to study and report to the General Assembly on a comparison of the regulation of PEOs in Maryland to other states and federal law, both in general and with respect to health insurance specifically. It also requires us to study the history of PEO activities and changes to the industry over time, PEO health plans and benefit designs, requirements for participation in PEO arrangements and in PEO health plans specifically, and finally, any potential impacts on Maryland's small group market of the proposed statutory changes relating to PEOs and health insurance. Finally, moving away from legislation, I want to close out the Life and Health Division updates with some reminders about network adequacy. As all the health carriers will know, last year was the first year that our recently revised network adequacy regulations for health benefit plans were effective. However, some of the new requirements do not go into effect until this upcoming July, and I want to remind carriers to review the regulations to make sure they include all the additional information in the access plans that is being required this year. We issued Bulletin 24-12 on April 29th to outline the submission requirements for all network adequacy filings due in 2024, including the new data reporting for health benefit plans that will be required for the first time in 2024. For health benefit plan filings, although the access plans are due on July 1st, the additional data reporting for out-of-network claims, complaints related to availability of providers, and telehealth utilization is not due until October 1st. For dental plan filings, the executive summaries for 2024 are due on December 2nd. All filings should be submitted through SERF using the appropriate filing type and TOI or type of insurance. Carriers should also make sure they use the filing templates that are available in SURF, which are mandatory for the first time this year, and which provide additional guidance on MIA expectations for supporting documentation and methodology. And that closes it out for life and health, and I believe Mary Quay is up next.
Thank you, David. Yes, I am going to talk a bit about cybersecurity filings. And there are two types that I want to address. Section 33-103 of the insurance article requires carriers above a certain size to have in place an information security program and an incident response plan. Each year, on or before April 15th, a certification of compliance with these requirements must be filed with the commissioner, unless you meet the requirements for an exemption. This year was the first year that these certifications were due, and we are working through verifying that each company that appears to be required to file did so. If we did not receive a filing, we plan to follow up to review why a filing was not submitted. Records to support the certification are required to be kept for 5 years. We are planning to retain a firm with the appropriate expertise to determine whether the information security plans comply with the substance of the law, and you may be asked to provide the information security plans at that time. The other type of cybersecurity filing is an event report required by Section 33-105. There is an online form for these submissions. You should expect to file the information security plans and incident response plans as part of the reporting. And I want to thank everyone who has filed, especially if you filed indicating that you might be exempt from future cybersecurity filings, because that way we will have it in our records for subsequent years. And thank you for everyone who has cooperated with cybersecurity filings when there is an event. And the next thing I wanted to talk about was...
Hey, Mary, do you mind if I
Oh.
jump in I'm sorry,
No?
just for
Okay.
a second. No, I apologize because I hadn't warned you of this, but I wanted to just mention two things with regard to cybersecurity. First of all, I want to make sure that everybody is aware that if you are a domestic, if you are a Maryland domestic, then as part of your triennial financial examination, you go through a review of your cyber controls and your cyber information security systems. And those, of course, have now been aligned with the new statute to assure that there is a written program and that written program covers the areas it's supposed to cover, and they look at procedures, processes, controls. So I wanted to make sure that people understood that there will be consistency, obviously, between financial regulation and market regulation. And for those folks that are continuing to look at and work through their information security plans and what would need to be compliant, that review process through the financial examination process is a good place to start, because we will be, working through a very similar analytical process in the market conduct group. And that will align with what currently happens with financial examination. The other thing I just wanted to mention was more on a national level, is that Maryland and every other state that has passed the NAIC model is very aware of what may be a multiplicity of notice requirements in situations where there has been an event that has a national or a large regional impact. And so the cybersecurity working group is working right now with MAUG in order to develop a more coordinated, if you will, information gathering process that would make it easier for companies to meet all of their notice requirements, and also kind of coordinate the follow-up questions and delivery of information. So not really MAUG, because fact that an incident occurs does not mean there's any sort of a violation to investigate. But how do we make this process easier for those folks that have an obligation in state? So that is a process that you're going to want to start tracking. And there will be some discussion about this project at the national meeting. So sorry, Mary, I had to take over for a second, but I just wanted to make those 2 points.
Okay, well, I was going to switch topics now to the Key Bridge. The collapse of the Key Bridge and the reduction of operations at the Port of Baltimore, in addition to being a tragic loss of life, was a substantial economic blow to the Baltimore region. The MIA issued Bulletin 24-9 to ask for voluntary accommodations by carriers for policyholders affected by the disruption. And a list of carriers that notified us of accommodations is on our website with the resources related to the bridge collapse. And we want to thank the carriers that offered assistance or prevented lapses for those who were temporarily unable to pay premiums. It was heartening to see the community of carriers step up to support the small businesses and others affected by the bridge collapse. And thanks to all of you. And I believe that Joy is next on our agenda.
Thanks, Mary. Good afternoon, everyone. Joy Hatchett, Associate Commissioner for Consumer Education and Advocacy. And I am very excited and pleased to announce the beginning of a new effort here at the Maryland Insurance Administration called the HCAT, Health Coverage Assistance Team. And many of you may recall back in the 2022 session, there was a lot of discussion around the need to expand our ability as a state, not at the Insurance Administration, but just in general, recognizing that there were issues and barriers that consumers encountered when they sought behavioral health or substance use disorder treatment. And legislation was introduced that year to try to bring together the various state and private resources to solve that issue. Regrettably, that piece of legislation failed. Commissioner Borrain committed to starting a working group to further look at that issue and to see what we could jointly agree to. Regrettably, for several reasons, that also did not come to fruition. But if any of you know Kathleen, like I know Kathleen, she refused to let it go. And so she committed that this agency would pull together under the Consumer Education Advocacy Unit a team of individuals dedicated to trying to assist consumers with their behavioral health and substance use barriers, but also expanding that to basically what the consumer education team already does, helping educate consumers so that they can have a much better understanding of their health insurance coverage, how to get that coverage, resources if they can't necessarily obtain that coverage, and sort of walking alongside them through the process. Because as we all know, while we deal with this health insurance market all the time, the average consumer finds it a barrier. And sometimes before they even get started, they will give up. So we are very fortunate to have an incredible team of people that are working in the HCAT team. And I want to just take a minute and introduce two of those individuals to you today. First, our health insurance administrator, Patty Dorn. Probably many of you have worked with Patty over the years, and you probably most familiar with her in dealing with our seniors in their various issues and their issues in that area. And then we also have Ruth Getachew, who is joining us. Ruth, congratulations on just receiving your master's degree. And she has a lot of experience dealing with young people and assisting families of those young folks, getting the appropriate coverage that they need and overcoming the barriers. And while for most of you, you're still going to be dealing with the life and health and the appeals and grievance unit, because HCAT is not taking the place of those two teams. What we're here to do is, when a consumer is outside of a policy that falls within Maryland's jurisdiction, we're helping to fill that gap. Or if there's a consumer who's beginning to look for coverage or having questions about coverage, we'll try to answer that. But what we'll also do is connect them with the appropriate state agency. It's one of the things that we heard and we've been hearing when we've been talking to our many partners, is that there's lots of parts in Maryland, but we need to all come together, bring those resources together so that we can help consumers get to the right place. So we've been working on this now for almost a year. The launch of the HCAT will occur next week. So we'll be sending out a press release and all kinds of information. And for any of you guys that are at farmers markets, your libraries, you're going to see our outreach team passing out information, telling people how to get to us. And in the interim, if you have any questions at all about the team, how we can help consumers, please feel free to reach out. The main thing here is that we are here to assist Marylanders get through the barriers to getting their treatment that they need for their particular circumstances. So Patty or Ruth, do either of you have anything that you'd like to add? But then obviously I'm going to let Kathleen, if she has anything she wants to add, do that as well.
Nothing to add to the description. I think you did a wonderful job. Just to state that I'm really excited to work with this team. We have a group of really motivated individuals that are knowledgeable and just ready to help consumers in the state. So just wanted to express a little bit of excitement there.
All right. No
Commissioner,
other...
did you have, oh, go ahead,
No,
Patty, I'm sorry.
please.
Oh, no, I just said no other real comments for me. Just looking forward to launching next week. Like Joy said, we've been at this for almost a year. We've gone through over 500 test cases to get our processes in place to make sure that when we do launch this next week, we've had a lot of experience already.
Well, thank you, guys. Thank you, Joy. And thank you for everybody at the MIA that really has worked hard to bring this to fruition. Many of you may be aware of within our CEAU unit of something called rapid response, right? Which is when a person has a P&C problem, personal lines, the unit runs a program that has, identified problem solvers within the P&C companies. We're able to go to them. It's a pre-complaint process. So many times they're able to get things resolved really quickly because so many things are communication issues, right? So that rapid response program has been around for about, well, it started when I was here as principal counsel, so it's been around for probably 20 years now. And it works extremely well. This is not exactly the same thing, but it is adjacent to it in the sense that what we want to do is when people are having trouble understanding their coverage needs, or when they have coverage, but they're struggling to figure out how to use it, or they have coverage and they've encountered some form of barrier. Could be an actual denial, but oftentimes it's confusing for folks to understand what do they have to put together and where do they get this stuff and how do they manage asking for this and that and filling out all these darn forms that they have to fill out. So part of our remit here is when people encounter a frustration, that they have a place to go to help them work through that frustration. That what that solution means in cases may be sending them to the health exchange so that they can get that information. Or it may mean helping direct them to the right person within their carrier, like this is what you do. It may mean helping them understand, well, yes, the carrier is entitled to have this information. Here, let me help you figure out how to get that information so that you can submit your claim. Or it may be helping a consumer understand what is or isn't actually covered. And maybe your plan doesn't work for you. You should go back to the exchange or back to your agent and talk about what is a better plan for your needs going forward. So along all of those areas of then that journey, our goal is to be available to the consumer, to open a case, and to walk with that consumer throughout the entire process. So we have been a year in the making of this, but we've developed really great relationships with payers, with various other partners, as we've kind of worked through very efficient workflows. And probably most importantly, the MIA's first release on its brand new enterprise system, which is our journey toward true innovative technology, soup tech, 21st century data management and case management, et cetera. The first launch for Salesforce was HCAT, and it is impressive. And in addition to just being able to keep track of issues, I think the other and very important piece of this is that it's data collection. So we really can understand where are the patterns. And so we're able to help the policymakers, identify where actual needs may lie and to have data to back that up, as opposed to sometimes, what is our assumption, but not necessarily our driven with data or backed up by specific data. So this will be very helpful for that. So this is a program near and dear to my heart, and I am just so grateful for Joy and for Ruth and for Patty and the work that they've done and the lots and lots of help that we've had from lots of partners, including fellow state agencies. So much more to come on this for next week, but I just think it's going to be a great way to make the whole process of compensated care much more efficient and much more effective, and therefore then drive down the costs of uncompensated care. So thank you. Thanks, Joy, for letting me jump in.
Thanks, Commissioner, and thanks, Ruth and Patty. So the next very brief topic that I will talk with you about is, that June 1st started our hurricane season. And we have to talk about this every season, just as a reminder that in case we have a storm, and a lot of you probably know that there has been a report that they're expecting a much worse hurricane season than usual. And so if in fact Maryland has a major event, there may come a time when we have to reach out to you, either because, once again, we may be asking for an accommodation, or we may be asking for a waiver of the prescription drug or the DME requirements. So what I always tell folks is make sure that your contacts for disasters are updated. if people have come and gone since those were updated, please make sure that you reach out and let us know about any updates. And if you have any issues or concerns, please feel free to reach out. And that's all I have.
Thank you, Joy. I appreciate it. Let's see, give everybody the chance to raise their hand or ask a question. And I think that Craig, I think we have one person, Glenn Arrington,
Yes.
or maybe, yeah.
Mr. Arrington, if you could accept the promote to panelist, you will be brought over.
There we go.
Hi, everyone. First, I want to thank everybody for putting this on with the MIA. And my name's Glenn Arrington. I am the owner of Group Benefit Strategies in the heart of Bel Air, Maryland. I've been in the health and life insurance business for 31 years. 10 years working for Mamsie Optimum Choice to get bought out by United Healthcare. And I wrote a letter and have a concern as a broker and agent about the PEO bill. Sent it in. You know, the fact that the experience I have in this business is that we as small agents, I have about 250 small group clients. And just one other thing I want to mention, I'm also part of NAIFA Maryland and formerly Mahu on both boards, and also was part of the small group advisory committee when we went through the work study program there, trying to find subsidies for small group. And we have about 250,000 Marylanders in the small group market. My biggest concern is the fact that we are in a situation where if these PEOs are going to be able to come down to 2 to 50 employees, it's going to create a lot more pressure on the small group market to sustain the premiums. And it was mentioned that there's no historical value. I can just tell you, being in the business as long as I've been in it, that it will put pressure on it, because what these PEOs do, these payroll companies like ADP, Paychex, major PEOs, they offer HRAs, integrated products. And what they do is they then try to find a partially self-funded product or a self-funded product that incorporates everybody into the fold that's healthy. And then the population of the 250,000 Marylanders in small group will slowly get depleted to the point where we'll have a lot of unhealthy people in that market, and therefore it will cause some problems with our premium increase. It's bad enough they've averaged between, during COVID, 2 to 3%, and now they're 5 to 8 to 10 to 12% increases, and it's going to be tough to sustain it. But one of the major issues is transparency. There's no transparency. They bundle the products together and sell the HRA products and the payroll discounted to pick up the commissions that are paid to the agents. And as a broker, I can tell you, ADP, Paychex, and some others have tried to cut me out and say we only use our preferred brokers, our, so to speak, preferred or partnered brokers. And we will get a broker of record letter stating that we cannot be the broker anymore. That's not good for our clients, our small group clients that we've been serving for so many years, to have a big PEO type operation in small group take over, because we become their HR, we become their people of help when they need it. These small employers wear a lot of hats. They can't afford an HR company. So we are their HR department. So the transparency, and then if it gets bundled together, try to unbundle it. It takes months with problems. Okay. Those are two of my major concerns. Then there's the control factor. They control the group. And then
So,
last,
Mr. Arrington,
Yep.
Just meant, so everything that you're saying is very, very valuable for the insurance administration to hear.
Yep.
And what is helpful and very appreciated in your appearance today is to let us know that there is what the entire point of view, right? Because there are a spectrum of views. Maryland is one of only 3 states that takes this approach. In every other jurisdiction, PEOs operate often under statutes. And so we want to look at what is that meant for their small group markets, right? But we also want to hear your concerns and your experience. So here's what I'm going to suggest to you. It is our intent to have a public hearing on PEOs. It's not going to be able to happen before I exit on June 30th, but it will be scheduled as part of the work group and the development of the report process. And I think it will be very important for you to testify at that hearing and to provide any information or any details or any documents that you think should be looked at and considered. Also, our report is not about making a decision or a policy decision. Our report is about making sure that the General Assembly has accurate, detailed, up-to-date information. And that includes information that might lead you one way or information that might lead you another way, because ultimately this is going to be their policy determination through legislation. We just want to make sure that as they address that, because there has been a lot of discussion about it in recent years, that they're basing it on the best information we can make available to them. So what I would urge you to do is watch for that meeting, participate in that meeting, and then at any point in time, you are more than welcome to send to our team the information, any information you want us to review, because we're obviously in the final report, which is due in December. Again, I won't be here, but the nature of this administration and the ethic of this Maryland Insurance Administration is to make sure that we provide an even-handed, accurate, thorough, complete, and that will include a statement and recitation of all of your concerns and any information you provide that backs them up.
Understood.
So
Understood.
does that work for you?
Yeah, understood. And I testified in front of the House of Delegates, the Insurance 101. I was the NAIFA Maryland person who spoke in front of the delegates. So I have no problem testifying. I testified with the ACA back in 2014.
Awesome.
But one of the last things it will affect too is we're trying to generate in the small group market through the Maryland Health Connection small group, which I'm part of that advisory committee. And they don't have a PEO integration system. So we're trying to grow that too. That's going to put pressure on growing that. So I think, the MIA needs to be aware of the fact that that's another issue if you're trying to grow the small group 2 to 10 employee group sizes, to pull them out of the pool that could be a helpful pool for fully insured groups. So I'd be happy to be a part of it. So thanks for.
Thank you. Thank you. I very much appreciate that. I really appreciate the comments. It looks like we have 3 other folks whose hands are raised. Craig, I wasn't watching order, so let me let you pull
Kelly,
folks on.
Dominique, I believe, is next. And Kelly, if you could accept the promote to panelist. Also, I could just allow you to speak. Can you hear us, Kelly?
But I don't have the prompt.
We can hear you now. We can't see you, but we can hear you. Ms. Dominique?
Is it possible that someone else can go and I can go afterwards until I get my
Oh, sure.
technology situation figured out?
Of course. It looks
Thank
like
you.
Deb Steinberg.
Hi, thank you. My name is Deb Steinberg. I'm with the Legal Action Center. Just wanted to thank you for all of your work on improving access to mental health and substance use treatment. We're really excited about the new UR standards as well as the parity compliance. Also always really excited to hear about the consumer assistance program, the HCAP model. Specifically, your team mentioned that there would be greater data collection to improve policies. And I was just wondering if you could speak to whether that data would be public, if there's a way that consumers and advocates would be able to access it so that we could use it in our advocacy as well.
So the answer is pretty much no, because as they relate to people's personal financial information and personal health information. However, we would expect to aggregate and de-identify data so that we can report on trends, et cetera. But when someone comes to us for assistance, their file data is confidential. Now, they can choose to release information to an advocate or somebody, who they want to have access to it. But beyond that circumstance where someone's come in as their advocate and they allow us to interact with that person and share information, the answer is that we have to, by statute, keep it confidential.
Ms. Dominique has joined us.
Excellent. You're on mute now. There you go.
All righty.
Hello.
Thank you so much for your patience. Thank you, Commissioner Moraine, for your presentation today. Also, congratulations to Joy, Pat, and Ruth on launching the HCAT initiative. And so my question is specific to that. Will the HCAT address education concerning patient privacy rights and patient information access as consumers navigate their health insurance journey?
So I'll let Joy speak to this more precisely, but HCAT isn't designed necessarily. So consumer education and advocacy is the larger group through which all of our consumer education relating to insurance happens. And that includes sessions on broader topics like understanding privacy or understanding HIPAA. And we have materials on our website that help with that. So the education, so HCAT is not focused on broad education. It's focused on one-on-one consumer assistance in which one-on-one education is happening and assistance is happening. From a broader perspective, Patty's team in particular does about 3 or 4 webinars a week, most of which are on healthcare issues and true broad consumer education. If there are topics that you feel that we're missing and it would be valuable, we are overjoyed to add to our, cachet. And we often partner with folks that come on and help address topics. So if there are topics that you feel we should be hitting on, then I would ask you to get in touch with Joy and Patty in particular and let them know what they are.
Excellent. Thank you very much.
Commissioner, next we have someone from Sandy's iPad who joined us.
Hey, Sandy. You're on mute.
Oh, now I'm off.
There you go.
Thank you very much. I've been in this business a long time, remembering when your father was commissioner. So it goes back a very long time. And thank you for all your service and everything else. But I'd like to just endorse what Glenn said before. I agree. I've had that experience. I've been in this business a long time. And Maryland is unique in how far and strong we've done to try to develop the small group market, protect that market. And I'm also very afraid that if we let the PEOs advance and take groups, it will hurt the market significantly and we'll end up in a death spiral eventually.
Well, I thank you for sharing your views with us, and please keep watch for notice of when we will have a public session to hear everybody's views on PEO usage in the state, particularly with regard to the under 50 and the access to large group products. But also feel free to put your thoughts in writing to identify any of the issues that are identified as part of the study and any materials you have. So we'll welcome that input at any time.
Okay, thank you very much.
You're welcome. And I think Allison?
Allison Taylor, yes.
All right. Hey, Allison.
Hey, I just wanted to say congrats on the end of your tenure. You've taken on and tackled a number of really difficult issues, and I think have a lot to be proud of your tenure here. My question is, when can we expect an announcement about a successor for you?
I can tell you that there is no one at the moment, and I'm, in pretty constant contact with the governor's office in terms of, the process that they're going through, which they are still going through. This may be a situation, I don't know, but this may be a situation in which we might anticipate the appointment of an acting for a short period of time. But I can tell you that it is the search is front and center, but it is not concluded yet.
Got it. Well, thanks again for your service, and best of luck in your next endeavors.
Well, I thank you, and and I'll just take a second here, because unless there are any other matters, anything from the team, anybody else who wants to be heard? I don't see anything, so I'll just take a moment to say that it has been my great pleasure to have been able to be in this role. And to work with the people that I get to work with every single day at the MIA. And we have a great team in general, but I will tell you that our life and health team across all of the divisions is just world class and amazing. We have so much talent, but more than just talent and skill, both of which are important. We have people that are really passionate about what they do and really care about what they do. And that's what makes the MIA in general and the entire life and health team in particular even more special. So it's been my real honor to be able to be part of that team, and frankly, simply enable them to do what they do best. I am really proud of the work that this group did with respect to network adequacy, with respect to mental health parity, with respect to, health coverage initiatives. And so it was a really bittersweet decision. I was excited in the ability to transition with the Moore Miller administration. The last year and a half of their involvement has just been spectacular. When our governor says he's heart-led but data-driven, he means it. And he has given us so much support and so many resources. So when I finally had to kind of come to the point of fish or cut bait with whether I was going back to DLA or not, it was a very bittersweet decision. But it was the one that made the most sense for me, frankly, at this stage of my career, and frankly, just at my age, right? Because I'm at retirement age, and so it kind of makes sense to step back into DLA at this point in time. But I will miss everybody. I will miss interacting with you folks, in Annapolis and other places around the state. But it's been a great ride, and this industry is great. You guys are really great. The people that we've had issues, we've had discussions, we've had disagreements, but all in all, this industry, and particularly the life and health industry, have just stepped up so many times, all through COVID, all through events. When we reach out and we really ask for support and help and ask for accommodation and consideration of the human beings that we serve, the human beings that are on the other end of that contract and those regulations, I have to say that you come through, and you're, for the most part, in almost all circumstances, really good corporate citizens and public partners. So none of that has ever gone unnoticed at the MIA, and that's been a big part of the pleasure of being here. So with that, I'm just going to say so long. I'm still around for another few weeks, so I'll be wreaking havoc on you until I walk out the door. But it has been a great pleasure, and I will miss folks, and I will mostly miss my team. So if there is nothing else, I think we'll probably shut down the recording, call this one a wrap, and see you in a little bit.